screen. All right. Hi, my name is Lilit Pilossyan. I am a rheumatologist. Today I will be presenting on this very interesting topic. I'm very excited for it. It's the environmental influences on autoimmunity. It is a personal interest of mine, and it also includes my specialty, which is rheumatology, so it's the best of both worlds. I hope you enjoy, and let me know if you have any questions. All right, I have no financial disclosures or conflicts of interest with the presentation of the presented material of this presentation. All right, so I'm going to start off this talk by just asking the question of what is autoimmunity? And simply, very simply put, it's basically a break of our immune tolerance leading to the production of autoantibodies. And it's this pathological response to these autoantibodies that leads to disease states of autoimmunity. And the next question to ask is, what is immune tolerance? So immune tolerance is the ability of the immune system to recognize self-produced antigens as non-threat while appropriately mounting response to foreign substances and antigens. And during this talk, I will talk a lot about loss of immune tolerance, and it's this loss of recognizing self and not reacting to self is what immune tolerance is. And when we lose that, there's a loss of immune tolerance, which leads to autoimmunity. And we will talk more about it. But I just wanted to share these definitions. And as we all know, autoimmune disease can be very systemic. It can include, diseases like lupus, vasculitis, which, can cause manifestations in different areas of the body, or they could be very tissue specific. What's interesting is that almost all specialties we encounter have some sort of autoimmune disease within their field. And all of us specialists and primary care doctors, we all deal with patients with some sort of autoimmune disease. For example, dermatology with bullous pemphigoid, gastroenterology with their inflammatory bowel diseases, renal doctors with IgA nephropathy, good pastures, neurology with myasthenia gravis, multiple sclerosis, endocrinology with their autoimmune thyroid diseases, type 1 diabetes, and of course, the notorious rheumatology with its wide range of autoimmune diseases. And this by no means is a complete list. The list goes on, but these are just few examples just to bring in mind how common or how often we encounter autoimmune disease within our patients. And what is the cause of autoimmunity? So unfortunately, this will be a common theme of it is mostly unknown, but it is definitely a complex multi-system involvement, and it's multifactorial. Definitely, for the most part, there is a genetic component. There's a lot of hormonal influences on the development of autoimmunity. For example, in lupus patients, specifically the hormone estrogen plays a role. Environmental factors, which will be the focus of my talk today, as well as dysbiosis of the microbiome, which I will also touch base on today and see how that also can potentially contribute to autoimmunity. My objective for this talk is to discuss a few common rheumatologic conditions and their environmental causes. Specifically, I will talk about rheumatoid arthritis and systemic lupus erythematosus. I will then go ahead and talk about dysbiosis of the microbiome. And lastly, I will touch base on COVID-19 and its association with autoimmune diseases, since we are in this time of COVID-19 pandemic. So let's go ahead straight into our first case. Here we have a 62-year-old male smoker with past medical history of hypertension, diabetes, presenting to clinic with 2 months history of progressively worsening bilateral hand and wrist pain. He has associated swelling, cannot open doors or jars due to his pain. He has associated morning stiffness lasting 2 hours, taking ibuprofen as needed 3 times a day with mild relief of his pain. The pain is usually worse in the morning when he first wakes up and slightly improves throughout the day. History of hypertension, diabetes. He is married with 3 children. And he, in his social history, we can see he smokes one pack per day for at least 20 years with occasional alcohol consumption. So his exam, most notable for his MSK exam, diffuse synovitis of his bilateral 2nd through 4th MCPs, his PIPs. He has some scoring of his bilateral 1st CMC joints, and also left wrist with synovitis along with right wrist with mild synovitis. Otherwise, the rest of his joints look okay. He has no rashes, no nodules. His labs show he has a mild leukocytosis of 12,000, anemia with hemoglobin of 11.2. He has an elevated sedimentation rate of 45 and an elevated CRP of 20. Definite high titers of rheumatoid factor and CCP antibodies. His viral hepatitis antibodies were both negative. X-rays of his hands show right hand showed degenerative 1st CMC arthritis. He does have small erosions in his 3rd MCP and 3rd PIP joints and positive ulnar variants. His X-ray of his left hand and wrist showed that he had a small erosion of the distal scaphoid. So these are not actually his radiographic images of his hands. However, I just wanted to point out with these images here, you can see some soft tissue swelling in X-rays of patients with early rheumatoid arthritis with no erosions yet. However, here, this is the same joint imaged through time, and how we have this nice cortical bone that's not disturbed and thick, and as time progresses, how it kind of thins out and eventually causes these erosive disease. I believe these are PIP joints, if I'm not mistaken, or maybe MCPs, and here as well, a little bit of erosion. So through time, if left untreated, definitely can capture erosive disease on radiographic imaging. So this patient had rheumatoid arthritis. I mean, this image is just a severe untreated form with subcutaneous nodules. But briefly speaking about rheumatoid arthritis, it's a chronic autoimmune inflammatory arthritis, which preferentially affects small joints. It affects about 0.24 to 1% of population. And it's 2 times more common in women than men. Usual age is middle age and older individuals with a peak incidence of 65 to 80 years old. It's interesting, however, if it does occur in men, they have a higher likelihood of developing extra-articular manifestations such as these subcutaneous nodules, ILD, etc. The incidence and prevalence is much greater in certain populations, primarily the Native Americans, and they are 10 times more likely to get rheumatoid arthritis compared to the rest of the population, especially, let's just say, in the US. And their disease is pretty actually aggressive and difficult to manage as well. So something to keep in mind. And lastly, there is a genetic predisposition associated with rheumatoid arthritis, specifically the HLA-DRB1, which I will talk a little bit more about in upcoming slides. So the clinical manifestations, pretty much similar like the patient we just went over. Joint pain, swelling, especially of the small joints in the hands, wrists, and feet. Usually morning stiffness lasting several hours. Usually axial skeleton is spared, aside from the cervical spine C1, C2. And that usually happens with severe long-standing disease. And if left untreated, the C1, C2 rheumatoid arthritis, then it can cause neurologic compromise. Just something to point out how the axial skeleton is not really involved compared to our other inflammatory arthritises like spondyloarthritis, where the spine can be involved. If rheumatoid arthritis is left untreated, it can definitely lead to joint deformities and functional impairment. And 75 to 80% of patients with RA will test positive for both rheumatoid factor and CCP. And so just kind of to keep in mind that, about 1/4 to 1/3 of patients can actually have negative either RF or CCP or even both. So clinical presentation also really matters. And this image is just a patient, looks like it's a long-standing untreated disease. So now we're going to discuss the environmental causes. So as we previously reviewed rheumatoid arthritis, there's a lot of components, and environmental is a big part of the development of rheumatoid arthritis. And of all the environmental causes, cigarette smoking, it has the biggest role in triggering the rheumatoid arthritis, along with contributing to the severity of the disease. The other two that we will talk about is silica, as well as this one bacteria, P. gingivalis, which is found in our oral cavity. And I also wanted to kind of go over this HLA-DRB1 allele. So as we humans, we are diploid organisms, meaning we have, for each gene has two alleles, and each allele is inherited from one of our parents. And on this short arm of chromosome 6, we have the specific HLA region, and in particular, this HLA-DRB1 region. And this area is highly polymorphic, and there's and it's thought to play a role in the pathogenesis of rheumatoid arthritis. And just to kind of lay out some definitions for everything else to make a little bit more sense. So the HLA-DRB1 polymorphism, if there is 4 sequence amino acids that are found that predispose patients to rheumatoid arthritis, that kind of allele is called the quote unquote shared epitope. So we will see shared epitope allele. That just means, the allele that is responsible for the development of rheumatoid arthritis. And all it is just the 4 sequence of amino acid pattern that is found on the HLA-DRB1 allele. And so cigarette smoking, as I mentioned, is the strongest known environmental lifestyle risk factor. And there's a dose-dependent relationship between smoking and in patients with having the specific allele. So whether you have 1 allele or 2 alleles, there's definitely a dose-dependent relationship in that as well. Excuse me. So I think this slide demonstrates very nicely how having that allele, the shared epitope allele, and smoking increases your relative risk of developing rheumatoid arthritis. So here we have someone who's never smoked and has negative of the pairs of alleles, and so they're considered the reference group. However, we have here, jumping down here, we have someone who's never smoked but has 2 copies of these shared epitope alleles. Their relative risk for developing rheumatoid arthritis is 5.4. And then moving one down, someone who smokes, let's just say, and has 2 copies of the shared epitope allele, their relative risk for developing rheumatoid arthritis is 21. So nearly 4 times higher relative risk of developing rheumatoid arthritis in the same genetically susceptible individual just by smoking alone. So significantly there as well. So here too, someone who just smokes and has none of the alleles, they still have a slightly higher risk of developing rheumatoid arthritis as well. So smoking is definitely a big player in triggering it. So the next question we ask is how does smoking cause or trigger rheumatoid arthritis? And it's essentially, we get, smoking, inhaling the smoke from the cigarettes causes stress on the body and inflammation. And basically the immune systems get activated and release an enzyme called PAD, which is protein peptylamine arginine deaminase. And so what happens with the PAD is that arginine gets converted to citrulline, and arginine is a amino acid that's known to our body. It's versus citrulline is not. So citrulline now becomes a neoantigen that our body has not seen before. I mean, our body did create it, but it's not something that we usually show up for or make. It's because of the PAD. And also the same with CARP, which is carbamylene. And so now our body immune system recognizes these neoantigens, develops antibodies such as anti-citrulline protein antibody, anti-CARP, anti-MMA, and these antibodies then go on and develop joint inflammation and destruction. So the actual mechanism is definitely much more after the production of antibodies, but at least to know how are these antibodies formed, and it's from the PAD that's released from the inflammation of smoking. This is just, again, a different illustration. We have genetics here, and then we have smoking releasing PAD and causing citrullination of the protein, activates cells, and these antigen presenting cells then take on these citrulline molecules, present it to T cells, then B cells, produce these anti-citrulline protein antibodies, eventually form immune complexes, a lot of inflammation, TNF expression, joint destruction, and inflammation. All right. So our next topic, or our next thing we will talk about environmental influence, will be silica. And silica is known as the silicon dioxide. It is and it's an abundant mineral that's found. About 95% of our Earth's crust has silica. And it is a mineral found in rock, sand, soil, clay water. And usually like that, it's not harmful. However, in people who mine or drill, where the silica becomes almost aerosolized and very fine, it could get, we can inhale that silica. And I think somewhere along, if it's less than 10 micrometers, then it's not even visible to the eye, but we're able to inhale it. And that's where we get exposure. So highest exposure in these dusty trades, meaning mining, sandblasting, glass making, drilling, and it's also used in products we use daily almost, paint, skincare, certain skincare products, fillers. And it's interesting that they found that prolonged work exposure at the World Trade Center following 9/11 was associated with a greater risk of developing autoimmune disease, particularly in people, particularly rheumatoid arthritis. All right. So here, just a demonstration. This table just demonstrates how silica exposure increases your risk for developing rheumatoid arthritis. And not only that, but also how there's this synergistic effect with smoking and silica exposure. So here this table shows how this group with no silica exposure compared to this group with silica exposure. So in people with rheumatoid factor positive RA who haven't smoked but have silica exposure, have a 1.8, so 2 times odds ratio of developing rheumatoid arthritis. However, those who have silica exposure and have smoked over here, the odds ratio goes up to 5.4, which just illustrates silica exposure alone increases your risk for developing rheumatoid arthritis. However, both smoking and exposure to silica has a synergistic effect and makes your likelihood higher. All right, so what is the pathophysiology of silica exposure and autoimmune development? Unfortunately, it's not fully understood, but what's thought is that these small silica particles that are respirable are deposited in our alveolar spaces. And then these particles are phagocytized by alveolar macrophages, and these mucociliary movements of the macrophages helps clear them out. But at high concentrations of silica, the mucociliary clearance gets overwhelmed and it's impaired. And now we have this accumulation of silica-laden macrophages within our lymphatics and interstitial spaces of the lungs. And these macrophages are just now able to act with all other immune cells, contributing to autoimmunity. But as we all know, silica as well can stay in the lung and contribute to lung fibrosis as well, which is a silicosis and a pretty devastating lung condition to have. And lastly, with rheumatoid arthritis, I wanted to discuss this bacteria, P. gingivalis. It is the leading pathogen causing chronic periodontitis. And what chronic periodontitis is just this the disruption of the tissues that surround the teeth. So when we have chronic periodontitis, our oral mucosa kind of gets destructed, and this bacteria is able to enter our systemic circulation. And interestingly here, P. gingivalis also contains PAD, the same one we saw with rheumatoid arthritis, and it covers the arginine residues to citrulline, and the same cascade of process continues as with smoking. Here's just a quick illustration of that. We have P. gingivalis releasing PAD, causing citrullination, and the citrullinate protein gets detected by the antigen presenting cells, gets taken to T cells, then B cells, and all this inflammatory cascade again, and developing of these anti-citrulline protein antibodies. All right, so that was rheumatoid arthritis. So now we will move on to our next disease state. We have a 39-year-old Hispanic female who has a history of hypertension, presents to clinic for joint pain in her bilateral hands. Her joint pain has been going on for 2 to 3 months. It's intermittent, worse in the mornings, improves with use throughout the day, but overusing it also exacerbates the pain. She takes Tylenol as needed with some relief for a few hours. She also mentions that she has developed a skin rash on her face and upper extremities, worse with sun exposure. And in fact, she had just gone to the beach last weekend and noticed a rash on her face and upper extremities get worse. So she denies any pruritus, no fevers, no chills, and the rest of her review system is essentially negative. Her past medical history, she just has hypertension. She's married, 2 kids, and works at a front desk of a law firm, doesn't smoke or drink, and family history is significant for a maternal aunt with history of lupus. Her physical exam is most notable for, again, her joints. She has synovitis in her MCPs and PIP joints. Her skin, which this isn't her again, but it's a classic picture of what she looked like. It's this erythematous maculopapular rash involving her face, sparing the nasolabial folds, similar rash on her neck and extensor surfaces of her arms bilaterally. And her labs show that she is leukopenic with a WBC count of 3.0 along with neutropenic, neutrophils of 1200. She is anemic with hemoglobin 10.5, thrombocytopenic. She does have a high SED rate of 40. CRP is normal, and her antibodies is positive ANA 1 to 320, which is a high titer, positive double-stranded DNA and Smith. She has low complement C3 and C4, normal antiphospholipid antibody profile, normal UA, and a spot urine protein creatinine ratio of 237. X-ray bilateral hands from the PCP were reported normal. So the prevalence of lupus, so this patient has lupus, just classic presentation of lupus, and both, clinical presentation, lab findings, just she meets classification criteria for lupus. And so the prevalence of lupus is 20 to 150 cases per 100,000 person years. The disease onset is usually a little bit younger than rheumatoid arthritis. It's 16 and 55 years of age. It's higher among Asians, Hispanics, and African Americans. And it occurs, again, more in women than in men. And then, like we said before, it's attributed by an estrogen hormonal effect. Men, however, when they do get the disease, have a more severe manifestation of the disease. They have more major organ involvement and higher one-year mortality rate. And unfortunately, lupus in children tend to be more symptomatically severe than in adults. What is the cause of lupus? We all wish we knew. It's definitely multifactorial. And like we said, the genetic, hormonal, and environmental component to all of this. The estrogen predisposes the women to develop lupus. Genetics accounts for reported 28% of susceptibility of lupus. So there's likely a large component of environmental and epigenetic influence. And of course, I'm sure there's still uncovered genes that we don't know about that contribute to lupus. I just, wanted to bring out this slide just to show how a heterogeneous disease lupus can be. It can vary from just mild joint pain, skin manifestations to wicked nephritis, or other major organ involvement like CNS lupus or serositis, vasculitis. So it's pretty heterogeneous, and diagnosis, as we did with our patient, is definitely based on clinical and lab findings, and of course trying to alternatively exclude other diagnoses. So just here is a patient with long-standing lupus, likely untreated with the Jacquard's arthropathy. Here we have a nail manifestation of discoid lupus. This over here is like our patient with acute cutaneous lupus erythematosus, likely maybe to sun exposure. And here is a histology slide of a glomeruli. I think it was a membranous glomerulonephritis. All right, so I will now discuss some of the environmental causes of lupus, and the two major ones that I will talk about are viruses and UV light. But just like rheumatoid arthritis, silica dust has also been found to contribute to the onset of rheumatoid arthritis, lupus, along with cigarette smoking. So the biggest player of viruses that cause systemic lupus is EBV virus, Epstein-Barr virus. So when we get infected with Epstein-Barr virus, or any virus in general, but particularly Epstein-Barr EBV virus, we make antibodies to the retrovirus protein. And these proteins of the virus are homologous to our self-nuclear antigens. So the antibodies we produced against the virus through molecular mimicry are now reactive against our own endogenous proteins or nuclear antigens. And we now develop autoantibodies to them. And that then triggers the onset of autoimmunity. So I will talk more about this and kind of explain molecular mimicry and how it just gets, how the autoantibodies develop. So this illustration here is where I want to kind of explain how these antigens, or so explain how we as humans start developing antigens or antibodies to self-antigens from a viral infection. So the term molecular mimicry. So EBV virus has this eBNA antigen, which we create antibodies to. And it's this red triangle right over here. However, this eBNA is very similar to a self-antigen that we as humans contain. It could be a nuclear antigen or whatnot, or a protein. And so we start developing antibodies. So our antigens bind to these eBNA antibodies as well. So here we have the binding of the antibody to the antigen presenting cell, and that goes to our T cells. And the T cells now have our self antigen bound to itself, and through the whole cascade of antibody production, our now B cells produce antibodies specifically to the self antigen. So this autoreactive B cell is able to produce antibodies to the self. You would think, our immune system is so smart, they should know better in terms of, once it reacts to self, it should not react to self. However, this is the, point in terms of genetically susceptible people to these diseases. Usually our immune system is goes through these selection process, and specifically negative selection. So our T cells and B cells specifically go through this process. Like T cells in the thymus, they all go, get processed there. And once they see that a particular T cell has too much activity or stimulation on self-antigen, that T cell gets, programmed cell death or becomes anergic and gets wiped out of our system, because we don't want immune cells in our body that are highly reactive to self-antigens. Versus same story with B cells. It can happen centrally in the bone marrow or peripherally in our spleen. They get the ones that are highly reactive get selected out, but somehow either through genetic predispositions or whatnot, we have these autoreactive B cells and T cells that pass these checkpoints and clear this, these check centers and get out into our circulation, and hence are able to develop the B cells or antibodies against self-antigen. So another kind of mechanism of how this also happens is, or how we develop antibodies to self. So the antibody that was created to the eBNA antigen from the virus was similar to a protein in our body. But however, proteins sometimes don't just come isolated, they could come in protein complexes as well. So this is what this is trying to illustrate. This is the protein antigen that's similar to the eBNA, but it's combined with other things to create a protein complex. However, once this epitope binds to the antibody, it gets again engulfed and gets presented to the T cells, and now the T cell took the whole thing in, and the whole now protein complex is being, instructed to make antibodies against. So now we have the presentation of this other part of the protein complex. And this is what is termed epitope spreading. So now not only do we have antibodies against the similar antigen, we have antibodies against other parts of the protein complex that wouldn't have been there if it wasn't for epitope spreading. And just should have mentioned it earlier, but epitope is the area of an antigen that binds to an antibody. So now we have more epitopes that we have created and more antibodies to self-antigens. All right, so EBV is not just known to trigger lupus, but also other autoimmune diseases such as multiple sclerosis, Sjogren's, and systemic sclerosis, and many, many more. Lastly, talking about UV light, we have this how UV light, like the patient we had who got worse rash with sun exposure, mechanism is unclear, but what's thought to happen is with UV exposure, we have DNA damage, which increases our reactive oxygenase species, causes damage to the DNA, and eventually the cell dies and it goes through apoptosis. A big part of apoptosis is, our immune systems to help clear out these apoptotic cells, because once a cell dies, all its intracellular components kind of leak out, and they're just potential antigens that can get stimulated to develop antibodies. So we want to clean out all that debris and mess, so we don't have any chronic antigenic exposure to our immune cells. However, in lupus, part of the pathogenesis of lupus, it's thought that there's this reduced clearing of apoptotic cells, and that just increases exposure to autoantigens. And that's what's thought to happen with the UV light causing apoptosis and impaired clearance of the cells, thus developing antibodies to intracellular components such as DNA material. And here's just another kind of picture describing it. And a big part of the cleanup process of apoptotic cells is our complement system, and particularly C1q, which is a molecule that is part of the complement system. And it's required to help clear these apoptotic cells by stimulating phagocytes to kind of engulf all these debris material and get them out of our system. However, interestingly, 75 to 90% of patients with homozygous are homozygously deficient in C1q and C4. And these people manifest lupus and lupus-like diseases. So it's this deficiency in C1q, either antibody production or just genetically not able to produce C1q, where it impairs apoptosis clearing, exposes autoantigens, and triggers antibody producing cells to develop autoantibodies. All right, next, moving on to the microbiome and autoimmunity. As we know, microbiome has become such a hot topic of conversation, research in the past 2-3 decades, and definitely a very interesting area to dive into. And it is thought that autoimmune disease can, the disruption of the microbiome can lead to the onset of autoimmune disease in genetically susceptible people. And I will demonstrate some studies to support that. So here, interestingly, our gastrointestinal tract is the largest immune organ in the body. 70 to 80% of the human immune system is within our GI tract, and us humans have co-evolved with the microbiome, meaning that we are not meant to be sterile. In the womb, when we are being born, we are in our mommy's wombs, we are sterile in a sterile environment. However, as soon as we come out of the birth canal, we are exposed to a whole slew of microbes that are our first test or first stimulus to help develop a defense immune system in our body. So the consideration of C-section babies that do not pass through the birth canal maybe have a disadvantage to developing that initial defense immune system. So our immune system, however, in the gut in our GI tract is separated from the microbiome by the beautiful intestinal epithelium. So there's a lot of evidence that suggests that there's this beautiful bi-directional dynamic interaction between the immune system and the gut microbiome. And dysbiosis, meaning disruption of the gut microbiome, and that barrier can trigger immune dysfunction, and it can contribute to the development of autoimmune disease and or allergic diseases as well. And as we know, our gut, gets exposed to a lot of things that we eat, antigens, foodborne pathogens. And so our commensal bacteria, which are our body healthy bacteria, have evolved over millions of years, and they live in harmony with us. And they have a lot of anti-inflammatory effects to the gut as well as our body. And they provide us with these essential nutrients that are very helpful for us. And they defend against colonization of opportunistic pathogens. So, if the ratio of the good bacteria kind of changes, then bad bacteria can now take over and cause disease. And there's 3 to 10 times more 3 to 10 times more bacterial cells in our body than human cells. And I read somewhere, I think it's 4 or 5 pounds of our weight is just from our commensal bacteria, including the skin, oral cavity, gut, and 100 times more genes, bacterial genes or microbial genes than human genes. And so the major functions of the intestinal microbiome. So nutrition, they really help with synthesizing vitamins such as folic acid, riboflavin, thiamine, and they also, half of our daily dietary requirement of vitamin K comes from these intestinal microbiome bacteria. And it also help process these complex carbohydrates that make a very important product like butyrate. And butyrate really helps nourish the intestines, has anti-inflammatory effects, and butyrate is one of the important things that the gut bacteria produce through these complex carbohydrates that are beneficial. And so all this just helps influence and shape the immune system. And this is just a nice illustration of our gut epithelium, intestinal epithelium, single layer of epithelium combined tightly together with tight junctions. So nothing can get through, and only, through intracellularly, nothing can get through paracellularly. And here we have the lumen, which consists of the commensal bacteria, the good bacteria, along with mucus. And here on the other side, we have our beautiful immune system. So any disruption to this will cause leaky gut, which is an unofficial medical term, I guess, which allows bad things, toxins, things that are not supposed to get in to actually get in. And I think this slide here illustrates that. So here it's a beautiful symbiotic relationship of the good bacteria with the intestinal epithelium and the immune cells. However, with certain genetic or environmental factors, this mucosal layer and this microbiome can be disrupted, causing dysbiosis. So now bad bacteria can now colonate instead of the good bacteria, and they can cause harm. They can cause disruption of these tight junctions, eventually leading to inflammation and translocation of the probions or toxic substances into our systemic circulation and trigger either autoimmune disease, inflammation, allergies. For example, here we have P. gingivalis, which was also an oral bacteria. It's not supposed to be here. And so or at least in large quantities. And when they are here in large quantities, they're considered pathobions. And this other bacteria, E. gallinarum, which I will talk about in a few slides, is thought to trigger lupus and has been shown to trigger lupus in genetically susceptible mice. And some of these environmental factors, just to kind of touch base on, it can be our westernized diet definitely has a big influence on disrupting this barrier and causing dysbiosis. And also overuse of antibiotics, I think, can contribute to the dysbiosis, killing off these good bacteria and making room for bad bacteria to take place after it's all wiped out. So just some things to keep in mind. So what happens, just a kind of like a summary here. Dysbiosis of the gut, oral and skin microbiome cause any disruption, can induce inflammation and cause loss of immune tolerance. And it's definitely linked to several autoimmune diseases, such as inflammatory bowel diseases, primarily, given, there's the source, multiple sclerosis, RA, and lupus. And here is the very, very interesting slide I wanted to talk about with that one probiont that we saw, E. gallinarum. So here, interesting study that was done where they had genetically lupus-prone mice who were inoculated with E. gallinarum, and they noted that E. gallinarum translocated from the lumen so caused disruption of the epithelial barrier, translocated into the body, went to the liver, and caused all these antibody production, interferon synthesis, inflammation, and early death. So these mice pretty much developed lupus. They tried to inoculate this lupus-prone mice to other bacteria, but there was no translocation noticed or witnessed or reported. And then interestingly, when they give antibiotics or immunization against E. gallinarum, there was no translocation of E. gallinarum. There was prolonged survival and very low levels of autoantibodies. In comparison to a healthy mouse with normal genetic makeup, they inoculated with E. gallinarum, there was no translocation. Then they tried to colonize only with E. gallinarum, so higher, load of it. And there was translocation and some antibody production against double-stranded DNA and some lymphocytes, but not as bad as the lupus-prone mice. And then they tried to infect it with another bacteria, such as salmonella. There was translocation, but there was no signs of lupus. So very interestingly, this shows how E. gallinarum somehow or another can trigger lupus in genetically susceptible individuals, and how giving an antibiotic or vaccinating against that bacteria can prevent the onset of lupus. But of course, there's still so many questions to answer. What is it about E. gallinarum that triggers lupus? And are there any other bacteria that can do the same? But it just shows the importance of maintaining a healthy gut in general, with a good epithelial layer and mucosal layer, and just keeping good bacteria to prevent pathogens like E. gallinarum into our body. All right, and then the last third of this talk will be about COVID-19 and autoimmune diseases. So as we know, we are in the midst of a pandemic. And so with COVID-19, we've noticed some people do well, meaning they recover quickly, but there's unfortunate individuals who have severe disease and eventually die from the overwhelming immune response. So there have been similar immune reactions that are seen in COVID infections and autoimmune diseases. And we now use medications that we treat for autoimmune diseases. We use them for critical cases of COVID-19. And it's thought that the COVID infection can trigger cross-reactivity through molecular mimicry, leading to autoimmunity in patients with COVID-19. So the question we ask is autoimmune disease a late onset manifestation of COVID-19? And the answer is we don't know, but I wouldn't be surprised, just like how EBV triggered autoimmunity in genetically susceptible people. And so with severe COVID-19 disease, there's just this excessive production and release of pro-inflammatory cytokines and chemokines that causes severe organ damage. And that same process is seen with severe autoimmune diseases as well. And so the immune system in COVID-19 is a double-edged sword. So we want the immune system to help combat the virus, develop, an immune attack towards it, get rid of it, and develop antibodies. So next time we see that virus again, we know what to do in a quicker fashion. However, once the immune system kind of goes on overdrive, when it's supposed to calm down, it just continues to grow and there's no stopping it. That overdrive is what causes inflammation diffusely through all over the body and leading to the severe COVID-19 patients that are intubated in the ICU and all that. So here's just a demonstration, for COVID-19. It obviously affects our both adaptive and innate immune system, activates all these cells, a lot of cytokines, interleukins, antibodies. And when we don't stop what's known as the cytokine storm, macrophage activation syndrome, and a lot of injuries that are immune mediated to all our major organs, and leads to the severe COVID-19. So that's one process. The other process is, once we develop these antibodies to COVID-19 for our own protection, is there molecular mimicry that goes on that later further contributes to autoimmune disease. And this table just explains how, similarities between severe COVID-19 and autoimmune diseases. We even see antibodies that come up positive in COVID-19 patients. And the drugs that we use as well, that we use in autoimmune disease, as I mentioned, we used in severe COVID-19. Some examples being steroids, dexamethasone, JAK inhibitors such as baricitinib, IL-6 receptor antagonist, tocilizumab, and sirolimus. And again, it's this molecular mimicry by the infectious pathogen that is believed to be one of the mechanisms of triggering autoimmune disease. Yeah, we talked about this already. There's a large number of reports of antigenic mimicry between viral and human proteins, such as EBV in lupus and MS. And so just a few examples of how the epitopes, which are the parts of the antigen that bind antibody. So some of the epitopes of COVID are shown to have cross-reactivity with autoantigens. And so, for example, in patients who develop the respiratory failure in COVID, so the unique S1, S2 cleavage site of SARS-CoV-2 virus is identical to the furin cleavable peptide sodium channels, which play a critical role in homeostasis of airway fluid, surface fluid, liquid. So what happens is we develop these antibodies against COVID at the cleavage site, but then these antibodies also, given how similar the antigens look, these antibodies attack self-antigens on these sodium channels, and maybe that just induces a whole slew of inflammation, causing the respiratory failure we see in COVID. Another thing with autoimmune disease in COVID, so we have these some of the proteins that we again develop antibodies to from COVID. Those proteins share the same sequence of heat shock protein 90 and 60. And these are the two things that are associated with development of GBS and other autoimmune diseases. So again, the molecular mimicry game is also going on here with COVID. So the question, is autoimmune disease a long-term manifestation of COVID-19? There have been case reports documented of development of autoimmune disease after COVID infections, although rare. The mechanism is still unclear and not definitive, obviously. COVID-19 is a novel disease and the long-term manifestations are still unclear. And I will leave this talk with a last interesting case of a patient I just had, a 71-year-old Iranian male, history of insulin-dependent diabetes, and hypertension, hyperlipidemia, paroxysmal AFib, who came to clinic for diffuse body aches, stiffness, and weakness. So 8 weeks ago, he actually had COVID, which he recovered very well at home with no prescription medications needed. After recovery, he was feeling back to his usual self. 2 weeks after that, so 2 weeks after he developed COVID, he had this sudden onset of pain in his bilateral shoulders, arms, hip, thigh areas. He had difficulty standing from seated position because of the pain. He couldn't comb his hair or wear his shirts over his head because of the severity of the pain. He had morning stiffness lasting till noon during the day, improving after a hot shower. Noted some swelling in his hands, which came and went. Worse in the morning when he first woke up. He had severe fatigue and just a lack of motivation to do anything because of the pain and the fatigue. He took Tylenol for pain with little to no relief. So given how severe his symptoms were, his family decided to take him to the hospital. He was admitted for 2 weeks, had extensive workup done, which was all negative. He was eventually diagnosed with a PMR, started on prednisone 20 with significant improvement of his symptoms, and then discharged home on prednisone 20 milligrams. However, it was tapered off very quickly after 2 weeks. And with PMR, we know we don't taper prednisone off that quickly, or else we get a relapse of the disease. So sure enough, this poor gentleman presents to clinic with return of his symptoms worse than when he initially started. So now however, the new symptom has also now started. He has a severe right-sided headache, scalp tenderness on the right side. He's complaining of pain with chewing, cannot eat his cucumbers, and he denies no vision changes. And he himself restarted the prednisone 20 4 days ago with some improvement. However, his headaches have not resolved. And so labs from the week prior of him seeing me show that he had leukocytosis, neutrophil predominant. He has some anemia along with thrombocytosis. His labs showed his diabetes was still, a little not fully controlled. And he had an ESR of 130, which is significantly high. RF and CCP was negative, CPK was 33. So this patient, diagnosis of polymyalgia rheumatica with possible temporal arteritis, GCA, and the actually course is to be continued. He is actually still in the hospital awaiting a temporal artery biopsy. So we'll see the results of that. But the reason for this case here shows, 2 weeks ago, 2 weeks prior to the onset of his PMR symptoms, he had COVID-19 infection. So now the question we ask, was the COVID virus the trigger for the offset of PMR in this patient? And I think I have a high suspicion it was. And that is all I have to say. Thank you very much.